Hi guys! So for my presentation I got exertional compartment syndrome. It can be either acute or chronic and is defined as a condition which high pressure builds within the closed fascial space of the muscle, reducing capillary refill and tissue viability. Commonly it can be found in skiers, soccer players, runners, basically just any sport with overuse injuries. Fun fact is that it accounts for up to 75% of sports-related chronic lower extremity pain. Although it is mostly common in the lower extremity, it can be found in the upper extremities, such as the forearm. Etiology, basically one of the less common causes is blunt soft tissue trauma, but main cause of exertional compartment syndrome is overuse. Just the muscle swelling to swell secondary to the increased blood flow and fluid retention. And basically what happens is that because of the swelling in the muscle compartment, the swelling is so much that the compartments are unable to accommodate for it, and it can lead to nerve damage, and if left untreated without surgical intervention could lose the limb in a serious case. For anatomy and physiology, most commonly, like I said, acute exertional compartment syndrome occurs in the lower extremities, in one of the or more than the four compartments of the lower leg, which we all know are anterior, lateral, the deep posterior, and superficial posterior compartments. So just a little fact. Then I actually found a little fact that it occurs most often in the leg between the knee and the ankle, or the thigh and the knee, as well as in the arm between the elbow and wrist. So, yes. Now, for mechanism of injury, since exertional compartment syndrome does occur secondary to anatomic abnormalities obstructing blood flow and exercising muscles, it's when like I said, when the compartment pressures exceed the amount that the tissues don't receive the proper amount of oxygen, then the lack of oxygen can cause ischemia, it's cell death, and a bunch of other complications. When the next step of it is evaluating your athlete, most importantly, clinical findings show that while evaluating, if there is severe pain while passively stretching, it is a very high case that it is a form of exertional compartment syndrome. Always, if there is paralysis, paresthesia, or decreased pulse, it is a medical emergency. Get your athlete to the hospital ASAP. Then acute versus chronic. Acute exertional compartment syndrome. The symptoms will appear without prior notice. Like, you'll just randomly have signs and symptoms of it appear. We'll go over signs and symptoms in a moment. And then with chronic compartment syndrome, the symptoms are present while exercising, and once exercise is ceased, the symptoms will gradually disappear or subside. So some predisposing factors that would inhibit the athlete to maybe possibly be diagnosed with exertional compartment syndrome would be herniation of a muscle, tibial fractures, post-exercise fluid retention, diabetes, decreased venous return, increased capillary permeability, and even if your athlete is wearing athletic shoes with an increased heel height, that could be a predisposing factor as well. So how to know if your athlete is dealing or going to be diagnosed with exertional compartment syndrome? Signs and symptoms: you have the 5 P's: pain, pallor, redness, pulselessness, paresthesia, and paralysis. On top of that, there will be swelling, weakness of the localized area, foot drop, inability to, where you'll find the inability to plantar flex the foot, warmth of the affected area, and basically pain when flexing or pointing your big toe. Both acute and chronic exertional compartment syndromes do have symptoms will have appeared during exercise, although with chronic they will subside with the rest. Acute will remain. Now, diagnostic imaging techniques for exertional compartment syndrome. Most valuable way to detect exertional compartment syndrome is through an MRI. Basically will give you the most accurate reading. Another way, another testing device is by recording the pressures in the tissue space, compartmental spaces, and take them before and after exercise to see the amount of swelling that occurs. Managing exertional compartment syndrome. Since exertional compartment syndrome does not respond readily to anti-inflammatory medications, physical therapy, or rest, basically surgical intervention is the best way to manage the condition. Although if the athlete with rest feels better, once they resume activity, most likely the chances are of the compartment syndrome to show up again is very high. So basically, the goal of treatment, the treatment plan, is to just decrease the tissue pressure, save the limb, restore blood flow, minimize the tissue damage, and basically just get functionality back to the muscle. Just get the athlete back, which is why treatment usually begins with conservative management, including relative rest for 2 to 3 months with gradual return to sports activity. Like I mentioned before, if exertional compartment syndrome is left untreated, there could be a possible loss of the limb, renal failure, and just increased tissue pressure within the compartments, which is not good in a medical emergency. So, to surgical procedures, the surgical procedure that is most commonly done is a subcutaneous fasciotomy. Statistics show that recurrence rates after fasciotomy vary anywhere from 3